Hello everyone. Our today's topic is acquired deformities and physiotherapy management. Contents: Introduction, Definition, Physiotherapy management. Introduction. Acquired abnormalities. In these cases, a child is born with normal limbs, but they suffer a bone fracture during childhood that results in abnormal limb development. Acquired abnormalities can also be caused by one of the following diseases that impact bone structure. Rickets, caused due to vitamin D deficiency. Sorting according to origin. Congenital, transversal, whole cross section, 1/3. Acquired, disorder, rachitis, arthrosis. Congenital, longitudinal in sagittal plane, distal to elbow or knee. Acquired after injury. Causes of acquired bone deformities. First, traumatic. Second, inflammatory. Third, degenerative. Fourth, infectious. 5. Tumors. 6. Dietary. 7. Miscellaneous. Hip joint. Coxa valga subluxans. Part of DCC rotational and valgus component. Treatment: DVO, eventual pelvic osteotomy. Coxa vara congenita, acquired deformity with capital side slipped femoral capital epiphysis. Treatment: intertrochanteric or cervical OT. Knee joint. GENU. After inflammation, Blount disease, rachitis. Therapy: high tibial osteotomy, epiphysiodesis, epiphyseal distraction, extension by external fixator. GENU valgum. After inflammation, rachitis, chondrodystrophy. Therapy: supracondylic femoral osteotomy, epiphysiodesis, epiphysiodistraction, prolongation. Knee joint. GENU recurvatum. Rachitis, result of injury. Therapy: symptomatic, wedged, OT, correction with external fixator. Genuflexstum. Degenerative arthrosis, rheumatic arthritis, hemophilia. Total knee orthoplasty redress. Scoliosis, lateral curvature of the spine more than 10 degrees accompanied by vertebral rotation. Idiopathic scoliosis, multi-gene dominant condition with variable phenotypic expression and no clear cause. Multiple causes exist for secondary scoliosis. Measure spinal curvature using Cobb method. First, choose the most tilted vertebra above and below apex of the curve. Angle between intersecting lines drawn perpendicular to the top of the superior vertebrae and bottom of the inferior vertebrae is the Cobb angle. Referral guidelines and treatment. Initial spinal clinic assessment. First, in-depth history is taken. Second, scoliosis progression, pain, function. Third, past medical history. Fourth, medications. Fifth, social history. Sixth, objective assessment. Seventh, X-rays standing or sitting to establish severity. Bending films to identify flexibility, Cobb angle. Also check RECURVATUM. Physio pre-op planning. First, commenced as soon as the patient is listed for theatre, approx 6 weeks. Second, facilitate smooth admission and discharge from hospital. Third, early contact with local services is essential. Physiotherapy role. First, to ensure that optimal functional abilities are achieved post-operatively. Second, those functional abilities include A. Respiratory function. B. Muscle strength. C. Transfers or mobility. D. Postural management. Overall aim is to maximize independence following surgery in activities of daily living (ADL). Postural management is vital and should be considered throughout of all stages of spinal surgery. Seating. Wheelchairs should be in suitable corrective sitting system. Pre-op consider lateral supports, harness head support, tilt recline facilities recommended pre-op for any patient with scoliosis. Tilt recline vital post-op if fused to pelvis. Molded wheelchairs are not appropriate post-op. Local services to review post-op to ensure corrective seating system. If fused to pelvis, other sitting systems can be used if have recline. Local therapists to review postural support from sitting systems post-op. Post-op head rests, lateral supports, harness will be required to maintain optimal postural alignment. Sofas Bean bags are not acceptable sitting systems. Transfers. Hoisting. Children that are lifted pre-op may require to be hoisted. Hoisting is dependent on age, size, weight, and complexity. High-backed slings with head support recommended. Bones in slings are not necessary. Thinner sling ideal will be left in situ initially. Remember to consider that child may require increasing sling length post-op. Responsibility of local services to provide hoist training if new or different equipment has been supplied. Inpatient physiotherapy. Review day 1 post-op. Chest physiotherapy commenced. Passive or active movements or active assisted movements are initiated. Bed mobility, log rolling. Mobility or hoisting once medically stable. Liaison with local therapist. Ongoing until discharge from the hospital. Kyphosis. Definition. General term used for excessive backward convexity of the spine. It is the exaggeration of the posterior spinal curve localized to dorsal spine, also known as round back or Kelso's hunchback, a condition of overcurvature of thoracic vertebra. This causes bowing of the back, called as slouching posture. Types. Round kyphosis, gentle backward curvature of the spinal column. It is caused by disease affecting number of vertebrae, for example, senile kyphosis. May be localized to a spinal segment or may be diffuse. Dowager's hump. Fifth or sixth vertebra go for kyphosis. Mostly seen in elderly and in post-menopausal women who have osteoporosis. Management. First degree kyphosis. Relaxation of the body, especially upper back. Repeated stretching session of shortened anterior structures by bracing shoulder and maintaining position. Postural training. Mobilization of spine, scapula and shoulders. Diaphragmatic and coastal breathing exercises to emphasize on inspiration. Resistive exercises to weak longitudinal and transverse back muscles. Controlled pelvic tilt associated with abdominal and gluteal contractions. Second degree kyphosis. Brace with pads. Exercises to improve mobility and respiration to reduce overall impact of the deformity. Third degree kyphosis. Bone graft, spinal cord depression, spinal stabilization. Exercises. First, mobilization of the thoracic spine in hyperextension, especially in case of direct stiffness. Segmental exercises. First, passive postures in prone or quadruped position. Second, stretching of the anterior intervertebral ligament in a supine position with apex of kyphosis or block. Third, passive postures with at the end active extension. Facet joint mobilization in the three planes combining active and hyperextension, lateral bending and rotation with active hyperextension. The relaxation must be global and three-dimensional. These are the exercises. Global stretching. Global stretching with RPG. A French physiotherapist was teaching and practicing classical segmented physiotherapy. She gradually discovered the value of a global stretch of muscle chain in position with lower limbs and trunk flexed at 90 degrees. For the spine deformation is most often used in closed kinetic chain. Feet on the ground and hands resting in front of a support and horizontal extension of the trunk. Below are the images of the exercises. Neuromuscular control and equilibrium. Integration of the corrected posture during imbalance exercises. Neuromuscular control and equilibrium. At first, we can use the supine position on a Swiss ball. The physiotherapist maintains the legs of the patient, seeking to balance only with the upper limbs in extension and external rotation. The trunk being released. In the second step, the child is lying in prone position and he must straighten at maximum the spine, making a paravertebral muscle active strengthening in unstable posture. Below are the images of the exercises on a Swiss ball. Exercises. Stretching of anterior thorax muscles and hamstring in case of indirect stiffness. Pilates exercises are also useful for lengthening tension imbalance in the body with weak abdominal muscles, tight chest muscles and hamstring muscles, and a weak overstretched upper back. Integration postural correction. Stretching of anterior thorax muscles and hamstring in case of indirect stiffness. Extensor spinal and abdominal muscle strengthening in corrected position. Back education, muscular reharmonization, breathing exercises for costovertebral mobility. Exercises. Ergonomics. Staples 90-degree rule in sitting. In case of thoracolumbar kyphosis, there is often a horizontalization of the sacral slope with stable pelvis incidence at 53 degree. In these cases, ergonomic kneeling chair can be used. In case of accunated kypholordosis, there is often an increase of the inclination of the sacral slope. If the pelvic incidence is normal at 53 degree, we can use a triangular cushion slightly tilted backwards. Lordosis. It is defined as an excessive inward curve of the spine, differs from the spine's normal curves at the cervical, thoracic and lumbar regions, which are to a degree either kyphotic near the neck or lordotic closer the low back. The spine's natural curved position, the head over the pelvis, and work as shock absorbers to distribute mechanical stress during movement. The American Council on Exercise (ACE) identifies several that can benefit people with abnormal spine curvature. ACE recommend the following exercises for people with lordosis. Hip flexor stretches. To perform a hip flexor stretch, start from a kneeling position on a soft surface such as yoga mat. Cat and cow pose. To perform the cat-cow yoga pose, start on the hands and knees on the floor or yoga mat. According to ACE, to perform supine hollowing, a person should lay on the back with the knees bent and feet flat on the floor, about 1 inch from the buttocks. Extend the arms to the sides at shoulder level. Breathe deeply and allow shoulders to relax. Pull the shoulders down and back without arcing the back, and allow this position during the exercise. Introduction. Angular deformity of the proximal tibia in which the child appears is called as bow legs. Physiologic GENU is a deformity with a tibiofemoral angle of at least 10 degrees of varus, a radiographically normal physis, an apex lateral bowing of the proximal end of the tibia and often the distal end of the femur. Causes may be seen in one knee or both knees. Physiological: Blount disease, rickets or vitamin D deficiency, lateral ligament laxity, congenital pseudoarthrosis of tibia, coxa vara. Below are the X-ray images of physiological bow legs and pathological bow legs. As you can see, the curve angle in the legs, it is called as bow legs. Treatment. Special shoes are ineffective in prevention of treatment of GENU valgum. If the feet are in valgus and foot strain is complained, foot orthotics such as University of California Biomechanics Laboratory UCBL orthotics are appropriate to support the foot. They do not correct the GENU valgum but relieve foot strain, easy fatigability and foot calf pain. When the iliotibial band is contracted, passive stretching exercises for its stretching should be done. This will relieve valgus deforming force of the knee. The role of orthotics to control or correct GENU valgum has not been proven and is controversial. According to the body of literature, the only indication for a knee ankle foot orthosis KAFO is to support the knee ligaments and prevent them from overstretching. It is used in pathologic GENU valgum. In the adolescent with GENU valgum which is severe and marked mechanical axis deviation, surgical correction is indicated. Two methods of surgical management are available. Hemi-FE physiodesis is done by stapling and fusing the medial part of the distal femoral and the proximal tibial growth plates. Appropriate time is crucial. Despite all precautions, one may end up with overcorrection or undercorrection. Osteotomy of the distal femur and proximal tibia is performed in the skeletally mature patient. Neurovascular structures, particularly the common peroneal nerve and tibial vessels, are at a definite risk of injury. Gradual correction with an external fixator lessens the degree of neurovascular change. GENU valgum, also called as knock knee. Knees are deviated towards the midline of the body and touch one another when the legs are straightened. Non-operative observation of deformity and parent counseling, considered as first line of management for physiological GENU valgum in children of less than 6 years of age with valgus angle less than 15 degrees. Bracing, most used in progressive physiological GENU valgum for parental satisfaction, but limited use in pathological GENU valgum. Common splints used are mermaid splint, lateral single bar knee ankle, foot orthosis, shoe modification with elevating inner border of the shoe. Valgus knee treatment. Exercises: side plank, side step up, stationary lunge, single leg bridge. Mechanical intervention: use heel lift to enable ankle dorsiflexion and determine location of the functional impairment. IT band syndrome treatment. Prevention stretches: strengthening the hips and glutes is one most valuable treatment strategy for IT band syndrome. These muscles will control rotation of the femur, position of the pelvis, and ensure that IT band is not compressed or pulled away from the hip. Foam roller is a great way to help treat IT band syndrome. The pressure from the foam roller will help loosen the tendon and the fascia. Some of the preventive stretches and exercises are hip raises, lateral band walks, lying glute stretch, side leg raise, and squats. Valgus knee and those affected. Women are more likely to experience valgus knee due to increased Q angle caused by wider hips. Individuals that are involved in training that includes squatting, lunging, jumping, landing, climbing and descending stairs, gait or running. Mostly lower body activities. GENU recurvatum. This may be due to abnormal intrauterine posture. It usually recovers spontaneously. Rarely, gross hyperextension of the precursor of true congenital dislocation of the knee. Features: limitation of knee flexion from mild to severe. Effusion and other evidence of knee abnormalities are absent. Sometimes a dense band that becomes tense during flexion of the knee could be palpated at the proximal part of the patella bone. Patella is always located more upwards and sometimes outwards. Other features include: it is usually bilateral, common in identical twins, more common in females, and extremely resistant to conservative treatment. Treatment: when movement rehabilitation techniques fail to prevent disabling secondary problems, management with expensive aids and or doses of even surgery may become necessary. Physical therapy techniques proposed for treatment of GENU recurvatum include manual facilitation, 6-9 or Thorax 922 neurodevelopmental therapy, sensory stimulation. Techniques derived from the principles of motor learning and motor control and biofeedback. However, excluding biofeedback, effect of these interventions on knee hypertension, hyperextension, and adult hemiplegia. Electrogoniometric feedback for GENU recurvatum. Standard physical therapy treatment was based on the Motor Relearning Program (MRPS). Isometric strengthening of the quadriceps. This is the easiest way to strengthen your quadriceps muscle, especially when you are still too weak to do strenuous exercises. SLR, straight leg raises. While laying down, lifts your whole leg up and holds that for 6 seconds. Squats, step ups, biofeedback device. Coxa Vara. Normal neck shaft angle 120 to 140 degrees. Neck shaft angle of less than 120 degrees is called coxa vara. Developmental and acquired. Developmental coxa vara, isolated, may be bilateral, associated with a skeletal dysplasia, cleidocranial dystosis, metaphyseal dysostosis, other skeletal dysplasias. Acquired coxa vara, slipped capital femoral epiphysis, sequelae of avascular necrosis of the femoral epiphysis, can be traumatic femoral neck fracture, traumatic hip dislocation, post-reduction for developmental dysplasia of the hip, septic necrosis, other causes of avascular necrosis of immature femoral head, congenital femoral deficiency with coxa vara. Coxa vara associated with pathologic bone disorders, osteogenesis imperfecta, fibrous dysplasia, renal osteodystrophy, osteopetrosis. Other bone softening conditions affect the femoral neck. Developmental coxa vara. Treatment. Goals of the treatment: stimulate ossification and healing of the defective femoral neck, restore the femoral head shaft angle to normal, restore normal mechanical muscle function to hip abductors. Developmental coxa vara. Modality of treatment: corrective valgus osteotomies. Valgus osteotomy of the upper femur at the intertrochanteric or subtrochanteric level is the most effective way to correct the varus deformity. To rotate the proximal femoral physis from a vertical to horizontal position, relieving shear stress on it. To enhance ossification of the defect. Treatment. Non-operative treatment. Indications of treatment: less than 45 degrees, unlikely to progress. 45 to 60 may progress. Normal degree angle is less than 25 degrees. Will require close follow-up if non-symptomatic. Treatment: HE angle of 45 to 60 degrees, observation and periodic follow-up. Indication for surgery: HE angle more than 60 degrees, progressive deformity, neck shaft angle less than 90 degrees. Development of Trendelenburg gait. Surgery: subtrochanteric valgus osteotomy with adequate internal rotation of distal fragment to correct anteversion. Common complication is reoccurrence. If HE angle is reduced to 38 degrees, less evidence of recurrence post-operative spica cast is used for a period of 6 to 8 weeks. Coxa vara is also seen in Niemann-Pick disease. Coxa valga. describes a deformity of the hip where there is an increased angle between femoral neck and femoral shaft. Etiology: bilateral. Neuromuscular disorders, example cerebral palsy, often have concurrent femoral anteversion. Skeletal dysplasias, example Turner syndrome, mucopolysaccharidosis. Unilateral, trauma causing growth plate arrest. Treatment and prognosis: coxa valga can be associated with GENU varum and lead to increased stress and early degenerative changes in the medial compartment of the knee. Coxa valga can be treated with varus derotation osteotomy, VDRO, and angle blade plate fixation. We measured several radiographic parameters: the head shaft angle, HE angle, acetabular index, and migration percentage to reflect the severity of hip subluxation and femoroacetabular geometry. The head shaft angle and the HE angle are common measures of change in coxa valga deformities. Thank you.